This is a module on ventricular assist devices brought to you on Raaonline. This is just a primer about ventricular assist devices because the therapy is very complex and requires an in-depth knowledge about the suitability and the limitations of the therapy. Though VADs have emerged undoubtedly as an acceptable therapy in acute and chronic heart failure. As far as the scope of this primer is concerned, I'll be walking you through a role of the VAD, when to consider a VAD, which VAD to use, complications of a VAD, and as will be obvious because of the limitations of the VAD, what are the future directions in which VAD therapy can be improved. I am not including external counterpulsation, total artificial heart, IABP and details about ECMO, though I'll be mentioning it where relevant. Coming to the role of the VAD, the reasons why VAD has come into common therapy for heart failure is because of the limited efficacy of medical therapy to treat end-stage heart failure. Also, shortage of available donor heart and the increasing number of patients who do not qualify for a transplant despite worsening heart failure. All these three conditions have fueled the evolution of mechanical circulatory support and ventricular assist devices. Earlier survival rates of the first generation ventricular assist devices was about 52%. This is versus 25% for those on medical therapy. In 2012, around the time the HeartMate 2 started becoming popular, the survival rate has gone up at 1 year to 86%. Currently in 2020, the major event-free survival, now that is the index of the efficacy of the ventricular assist device, is approaching almost 70%, and that is significant. This is a major event-free survival because there are some devastating events which can happen on a ventricular assist device. So the 1 to 2 year mortality is comparable to a transplant. So that is where the VADs are slotted in. Because it's comparable to a transplant, those patients that fall in the first 3 criteria, because of this criteria, it is an acceptable alternative to use a ventricular assist device. Now, when I say ventricular assist device, most of the ventricular assist devices are for the left ventricle, though we will be addressing those situations which require a biventricular or a left ventricular with a temporary right ventricular support. Now, the mechanism of action of ventricular assist devices is quite simple. It just reduces the preloading of the ventricle by actively displacing blood. If you remember that an IABP or an intra-aortic balloon pump does not move blood out of the ventricle. It just aids in the ejection of the native ventricle, while a ventricular assist device per se actively displaces blood out of the ventricular cavity, thereby reducing or preventing distension, reducing the myocardial oxygen demand, and hence also reduces the deleterious effects of back pressure, which is manifested as a lower wedge pressure or a CVP, depending on which ventricle is unloaded. The second effect that is made by the ventricular assist device is that it increases the cardiac output by ejecting the displaced blood into the arterial system, maintaining perfusion and preventing organ damage. A very short introduction to the evolution of ventricular assist devices. Now, the role of the VAD has been due to the shortage of organs and because of contraindications of transplant, also due to end-stage heart failure, refractory to medical therapy. So, VAD development mirrors the progress of heart transplantation. There have been, now the VAD is an extremely complex engineering. The problem is that there are many engineering challenges to match a human heart. It beats more than 40 million times a year. The initial VADs were all mimicking the native heart, and pulsatility was included in the ventricular assist device. But pulsatility per se, it has a lot of disadvantages, engineering design elements. So this led to the evolution of continuous flow VADs. Now, they have the advantage of a lower power consumption, lower contact and movement and non-linear movement of blood components, therefore reduced hemolysis, lesser infection levels, sound levels, which is extremely important to the person who the VAD is implanted in, and the hospitalization equipment costs are far lower than that of a pulsatile VAD. Initially, there was resistance to the idea of continuous flow VADs because of physiological issues with the continuous flow. But later on, it was ascertained through lab studies that continuous flow really doesn't matter much as far as end organ perfusion is concerned. Though there are some issues with continuous flow, namely gastrointestinal bleeding, possibly due to a consumption of certain coagulation factors which might lead to an acquired von Willebrand's disease. Continuous flow also leads to degeneration of smooth muscle and elastin in the aortic tissue because the pulsatility is eliminated. It could also lead to stasis and thrombosis in the carotid blood and aortic valve cusps in some patients. Nowadays, 95% of the ventricular assist devices implanted are continuous flow.